Tonight it's our pleasure to invite Dr. Edward Sall, who is not only a dentist, but also a physician and also an otolaryngologist. And in Canada, we just call them ENTs, but this gentleman practices both professions on a daily basis, and you're going to get a wealth of information and perspective from him as he tells you what it's like to be able to do both sides. Dr. Sall's topic tonight is nasal airway obstruction and precision oral appliance therapy in the treatment of OSA. His bio is as follows. Dr. Sall graduated from the University of Vermont in 1976 with a BA in zoology. He obtained his dental degree from Columbia University School of Dental and Oral Surgery in 1980, where he spent a year in the study and treatment of patients at the TMJ and Facial Pain Clinic. In 1984, sadly, crazily, he went back to school and returned to medical school at SUNY Upstate Medical Center and graduated with an MD in 1987. He completed his residency at Upstate in otolaryngology, head and neck surgery, and became board certified in 1994. In 1992, Dr. Sall began private practice as an otolaryngologist and dentist with an emphasis on TMD, oral facial pain, general otolaryngology, and the surgical and medical management of sleep disorders. In 2000, Dr. Sall earned an MBA from SUNY Binghamton with an emphasis in healthcare. In 2012, he became board certified in sleep medicine. Currently, Dr. Sall is the CEO of Sleep Center of CNY and has delivered oral appliance therapy for 20 years to over 4,000 patients. In June 2018, Dr. Sall was named the medical director of Prosomnus Sleep Technologies with a role of increasing physician acceptance of oral appliance therapy. He joined Better Night in February 2020 to add oral appliance therapy to complete a best practice approach to the total continuum of care to the diagnosis and treatment of obstructive sleep apnea. Clearly, this man knows what he's going to speak about. We are so happy to invite to Canada Dr. Edward Sall, and you have our undivided attention, sir.
Well, thank you, David, for the kind introduction. And I feel very honored and privileged to speak to our Canadian colleagues on a topic that's very dear to my heart. You know, I think that we're going to go over a number of different things here, and just for a little bit of organization, the agenda, we're going to talk about nasal airway obstruction and really what it means, how we define it, and then how we deal with it, both medically and surgically. And then we're going to talk about the role of nasal airway obstruction and oral appliance therapy. I think we all know that patients who are treated with oral appliance therapy, if they have nasal obstruction in their mouth breathers, then they have a much more difficult time of being compliant with the oral device. And then specifically, we're going to talk about the Vivere, which is a non-invasive procedure for nasal airway obstruction. And the interesting thing about this procedure, and you're going to learn a lot about it tonight, is it's not currently available in Canada. And we'll talk about why that is, but I hope that it will be available in Canada in the near future. So just some disclosures, as David said, I am the medical director of Prosomnus Sleep Technologies, and I have my own website, which is stopsnoreandsleepbetter.com. What happened is I started my own telemedicine company about 3-4 years ago. And the whole idea was to empower dentists to treat their own patients. I know in different countries, Canada being quite different than the United States, as to how the referrals go back and forth, who can order a home sleep study, who can interpret it. We live in different environment. And even in the United States, it's different from state to state. And so I joined this company, Better Night, and we're a national telemedicine company. And our goal is to help dentists treat their own patients. Also, I'm a consultant to Aaron Medical. Aaron Medical is the company that is marketing the Vivere non-invasive procedure for nasal airway obstruction. So what happens when we look at upper airway evaluation and patients with sleep-related breathing disorder? What we're really trying to do is gain a better insight into the complex pathophysiology of upper airway collapse. And why do we want to do that? Well, if we can understand the pathophysiology and the anatomy, then more than likely we have a better chance of prescribing the right form of treatment. I'm sure you've all heard about drug-induced sleep endoscopy and how it's used to evaluate people for the Inspire. And you know, certainly with any evaluation of the airway, what we're trying to do is determine where is the site of obstruction, where are the multiple sites of obstruction. You know, the problem with some of these things prior to DICE is that it was static and was performed on a patient during wakefulness. And so any evaluation we do in the office can be compromised by the fact that it's an awake patient who is usually upright. So, you know, when we evaluate the airway, we're looking at different segments of the airway and how it can contribute anatomically and pathophysiologically to collapse of the airway. Now, you know, looking at the soft tissues of the upper airway, we're going to focus primarily on the nasal cavity, but certainly in your evaluation, you're going to want to look at the soft palate, the tongue, the tonsils, pharyngeal fat pads, the muscles in the lateral pharyngeal walls. And these are all things that in your standard dental exam for a patient with obstructive sleep apnea, you're comfortable looking at and evaluating. We do in the office a nasal evaluation. We look at the anatomy, and I'm going to show pictures of endoscopic evaluation of the nasal cavity and go over some of the anatomy that you might be able to see. What's really fascinating about this whole subject, and I must admit, you know, I'm in full-time practice as an otolaryngologist and sleep physician, and I do oral appliance therapy. As an example, today I did 2 sinus surgeries in the morning, and then I saw a full day of patients. And some of them are patients with facial pain disorders. Some of them are patients with obstructive sleep apnea. So I'm looking at the relationship between airway obstruction every day, you know, and I'm looking at it from both sides, so to speak. And but if you look historically, what is fascinating is in the time of Hippocrates, which is 460 to 370 BC, he wrote that snoring was a symptom of nasal polyposis. And then you can see on this slide here that the number of different researchers that have proposed a relationship between nasal airway obstruction or obstruction of the nasal cavity and snoring or excessive daytime somnolence. So the notion of the nasal cavity being obstructed or constricted and its relationship to obstructive sleep apnea is not a new concept. You know, it's interesting. We all know that in oral appliance therapy, Pierre-Robin syndrome was coined, I believe I could be off on the date. I believe it's in 1920s or 30s by Pierre-Robin in France. And that was the basis for oral appliance therapy. And, you know, when we think about our oral appliance therapy, is that a new form of treatment? No, it goes back well over 50 years. And when you look at this relationship, it's been discovered many, many years ago. The issue is that it's been ignored for many years. Okay. And you know, let's look at the anatomical, the nose in the evaluation of the airway. So it's the first anatomical boundary of the upper airway. And we know that nasal obstruction may contribute to sleep-related breathing disorder. And how do we breathe? You know, we have the nasal cavity, and it's important portion of our anatomy, and that the nose warms and humidifies air. And the interesting thing about it is that chronic mouth breathing is associated with nasal airway obstruction. And if you just think of yourselves when you have a cold or an upper respiratory tract infection, you may feel like you're not getting enough air. But if you were to do a pulse oximeter, put it on your finger, your oxygenation is probably very normal, despite the fact that you can't breathe through your nose. And why is that? Because you open up your mouth and you breathe through your mouth when you're obstructed in your nose. So what's the function of the nasal airway? The nose acts as a carburetor of the body. It warms and humidifies air and it filters air. And one beautiful example of this is when you have a patient who's had laryngeal cancer and they have a laryngectomy, there's no connection to the nose and the trachea anymore, because what's done in that operation is after the larynx is removed, the tracheal stoma is stitched to the skin. And so now they breathe directly into the lungs through the stoma that's stitched to the skin. And one of the things that happens to people chronically who have had a laryngectomy is they get crusting and scabbing in the tracheal mucosa. And the reason why they do it is because it's exposed to the air and they don't have the normal warming and humidification that the nasal cavity provides. Let's just look at a little bit of nasal anatomy right here. And this is an endoscopic view. It's as if you're facing the patient. And right here is labeled as the nasal septum. And here's the middle turbinate. And here's the inferior turbinate, okay? And this is a normal appearing nasal endoscopy view. I think what's interesting is I'll get patients referred to me all the time, please evaluate for nasal polyps. And a lot of those patients that are deemed to have nasal polyps, just the doctor is looking at the inferior turbinate. And so this is a normal structure. Could there be polyps? I'm going to show you pictures of polyps as well. Okay. And, how do we examine the nose? In the office, we do what's called anterior rhinoscopy. And, this is a speculum, right-handed person standing on the side, right-hand side of the patient, looking inside the nose. And what you see here in this picture is the inferior turbinate and the middle turbinate. This is the left nasal cavity, and this is a normal appearing nose. Now, with anterior rhinoscopy, and this is the concept I'm going to really develop during this talk, is that when we put a speculum in the nose in the past, what we would do is put the speculum in the nose, look at the turbinates, and we would pretty much go right by the nasal valve. And we're going to talk about the valve of the nose because it's the most critical area of airflow. And so here, for years and years, we would examine the nose and we put the speculum in, and the speculum is going deep to the nasal valve, and we're not really evaluating the valve, which is the major area of restriction of airflow. So here again is anterior rhinoscopy, where you have a normal appearing nasal cavity. This is the left nasal cavity. As we go over here, you can see a little bit more swelling of the inferior turbinate. And here is a situation where you have a severely swollen inferior turbinate. This is not a polyp, but this is an inferior turbinate that's swollen. And you can imagine how this would restrict airflow. So, looking at the anatomy, the structures we want to look at, and we're going to go over these, are the external nasal valve, which is really the rim of the nose, or the alar rim, the columella, which is the structure in between the two nostrils, the septum, the turbinates, and the internal nasal valve. Now here is another view of nasal airway anatomy, and this is a right nasal cavity. Right here is your nasal septum right here, and over here is the inferior turbinate. And you can see, as compared to the pictures that were shown previously, how obstructed this is. And you can imagine a person who's got a swollen inferior turbinate like this is going to have great difficulty breathing through their nose. So we're going to step away from anatomy and talk a little bit about pathophysiology and the mechanisms of nasal airway obstruction. We'll go back to a little bit anatomy after I go over these concepts, which I think are really critical pathophysiological factors to understand. So we have this thing called the Starling resistance model. Maybe you've heard of it. What it is we view the upper airway as a tube with a partial obstruction at the inlet, which would be the nose, and a collapsible segment downstream. So if you have further obstruction upstream, that's going to generate a suction force or negative intraluminal pressure downstream in the oropharynx, and this results in predisposed individuals to oropharyngeal collapse. So you think of the upper airway as this hollow tube, there's partial obstruction, and the inlet is going to lead to, in susceptible patients, collapsible segment downstream. And this is going to be exacerbated in the supine position. And that's due to postural reflex mechanisms, and actively, that is, and passively as a result of reduced hydrostatic pressure on nasal venous circulation. This is a very important physiological concept to understand in the pathology of nasal airway obstruction. And then, Fitzpatrick showed in 2003 that with normal breathing, we have a oral breathing bypass. So we always have the option of mouth breathing when nasal resistance exceeds a certain level. And when we switch from nasal to oral breathing, there's really, this is physiologically disadvantageous, and it results in unstable oral breathing. And so during sleep, the upper airway resistance is lower in nasal breathing than oral breathing, and the wake state is the same. So as we fall asleep, what happens is oral breathing normally decreases in sleep from about 7.6% to 4.3%. So what does that really mean? It means if you have nasal airway obstruction, you're going to switch to oral breathing. It's going to be unstable. It's going to cause the airway to collapse. And when the nose is almost completely obstructed, a switch from nose to mouth breathing occurs. And there's really a high physiological cost associated with that. Mouth breathing is associated with 2.5 times total resistance. You have a narrowing of the pharyngeal lumen, and you have a decrease in the retroglossal diameter as a result of further retraction of the tongue. That's going to lead to increased oscillation of the soft palate and redundant pharyngeal tissues. I'm sure you've all experienced, maybe in your own lives or in patients that you treat, that the patient who doesn't really have sleep apnea, but they snore a lot when they're nasally obstructed. Well, here's the reason why: because they have unstable oral breathing. And then there's something called the nasal ventilatory reflex, and that has to do with activation of receptors, nasal receptors during nasal breathing, and that has a direct positive effect on spontaneous ventilation, resulting in a higher resting breathing frequency and minute ventilation. And when you bypass the nasal airway with nasal airway obstruction, you're going to have reduced nasal receptor activation, a deactivation of the reflex, reduced spontaneous ventilation, and that's going to exacerbate or unmask a previously subclinical apnea and increases the duration of the apneic events. And then we've all heard about nitric oxide. It's produced in the nose and sinuses. We know it's a patent lung vasodilator, and it reduces the perfusion ventilation mismatch and improves overall blood oxygen. And so the total amount of nitric oxide varies according to the nasal flow, and a decrease of nasal ventilation would result in reduced nitric oxide delivery to lung and reduced oxygen exchange. It also has a role in maintenance of muscle tone and regulation of neuromuscular pathways as well. And the role in nasal regulation of obstructive sleep apnea with respect to nitric oxide is not completely understood at this point. So, going back to the kind of taking the pathophysiology and anatomy and kind of marrying them, so to speak, we see that nasal resistance is offered to the air by the nasal cavity, and it prevents catastrophic collapse of the lung, and it increases resistance offered by the velopharynx. And in addition, partial obstruction at the level of the velopharynx can increase nasal resistance exponentially. So let's look at these components of the nasal resistance. And we have the structures: the nasal vestibule, the nasal valve, and the turbinates. So here's the external nasal valve, basically the nostril here. And here's the internal nasal valve. And that's going to be the lower border of the upper lateral cartilage, the septum, and the anterior head of the inferior turbinate. This represents the internal nasal valve. And we know that the nasal valve is with the glottic space, the area where resistance to airflow is the most important part of the airway. And pharyngeal resistance is 4 to 6 times lower than nasal resistance. Let's go back to some endoscopic views. And here is what a polyp looks like inside the nose. So this is the right nasal cavity. And This is the nasal septum, and you can see this polyp sitting here. And the issue here in a polyp in the nose is here's the polyp is, here's the inferior turbinate, and this polyp is going to change the size of the nasal valve and cause increased nasal airway resistance. What about nasal status and sleep disordered breathing? We know that failures after surgery for snoring arise from ignored nasal obstruction or because CPAP is applied through the nose in the case of sleep apnea hypopnea syndrome. And the nasal conditions inducing higher inspiratory upper airway pressure will favor collapse of the pharyngeal walls. The nasal vestibule, as we mentioned, has compliant walls. Its tendency to collapse in response to negative pressure can occur during inspiration. And the flow limiting aspect of the nose is that Starling resistance model that we talked about. And the area contributes to nasal resistance during inspiration. So let's focus in on the nasal valve. So the nasal valve is the narrowest part of the whole nasal cavity. It's the maximum area of nasal airway resistance. It's anatomically just anterior to the inferior turbinate, and it's governed by the size of the inferior turbinate and the nasal septum. And the inferior turbinate has erectile tissue in it, and its swelling affects nasal resistance. I'm sure you've had patients, maybe you've done this yourself, used Afrin or neosynephrine. What that does, it's a vasoconstrictor, and it shrinks the tissue of the turbinates to make it easier to breathe. And here is just a picture of doing a nasal endoscopy in a patient. It's an easy office procedure. Again, looking at that nasal septum, inferior turbinate, middle turbinate, very normal looking appearance. Now you can see an enlarged inferior turbinate right here. This is the right nasal cavity as if we're looking at the patient, and this is going to obstruct airflow. And here's something that you may see. We're going to show some radiographs, particularly some of you may have cone beam scanners in your office, and you're often going to see radiographically what's called the concha bullosa. And a concha bullosa is an air cell that's grown within the middle turbinate. You see it in about 20% of the population. So let's say you were having a patient in your dental office and you were evaluating them for their airway, or you were thinking about dental implants, or whatever reason you decide to get an imaging study. You know, here's an example of a concha bullosa. You can see this structure here and this structure here are actually the same structure. They look very different because this middle turbinate is normal appearing, and this is an air cell from the ethmoid has grown into it. It pneumatizes it, and what it does is it blocks the outflow tract of the maxillary sinus. So you see mucosal swelling, and that's because this has blocked the outflow tract of the maxillary sinus on that side. And here's just another example of sinusitis, and it's secondary to bilateral concha bullosa. And at surgery, we often open these. Picture that this is like a book, and we're taking half of the book off. Now, if you were to see on a cone beam scan concha bullosa and there's no sinusitis, it doesn't necessarily mean it's pathologic. You're going to see it about 20% of the time. Okay. And we know that inspiratory pressure required to draw air through the nose is to the fourth power of the radius, and that's called Sall's law. So a small change in the improvement of the opening of the nasal valve relates to a large decrease in the pressure required to inspire air, and an increase in nasal airway obstruction causes an increase in inspiratory pressure, causing airway collapse and then increased risk of obstructive sleep apnea. The turbinates themselves can increase and decrease in size, and nasal congestions, as I mentioned before, may may help that in the short term. And there's something called the nasal cycle, important thing to know, because patients will say, well, my nose plugs up every couple of hours on this side or the other side. And that's normal physiologic changes. And if you were to look at a time-lapse photography of nasal endoscopy of the nasal cavity, you would see alternating vasoconstriction and vasodilatation of the turbinates in a 2 to 4 hour cycle. And that's normal physiologic. And here's something I want to go over now, because this is what is going to become an important thing that I think everybody who practices oral appliance therapy or deals with patients with obstructive sleep apnea should be very comfortable doing. We're looking at the nasal valve. This is called the Cottle maneuver, after Dr. Cottle. And what you do is you take your finger and pull the cheek to the side. And what that's doing, it's opening up the nasal valve. And we'll see some other demonstrations of that, but essentially, this is a test to determine, do they have a problem within the nasal valve. I'm sure you've all seen breathe right strips, and that's what breathe right strips do, is they open up the nasal valve, and that they've been around for a long time. You used to see them a lot of sporting events, the basketball and football, maybe hockey players in Canada wearing them, and you don't see it as much now, but certainly that the breathe right strip works if there's a nasal valve problem. And so, just as a side little example, it's a little bit different when I do a Zoom presentation. I had a friend of mine who had 2 septoplasties. He's actually an ENT facial plastics physician practicing in Long Island. And I went down to visit him while he was doing his fellowship. And I get in his car, and he had literally, I don't know, maybe 80 breathe right strips on his dashboard. And I got in the car and I said to him, "What are you doing? What are these things here? Why are you doing this?" Well, he had 2 septoplasties and he couldn't breathe in through his nose because he had a problem with his nasal valve. So he would sleep with a breathe right strip. He'd drive to the hospital, and as he pulled into the parking garage, he would throw the breathe right strip on the dashboard. And that's why they were all there. But I think it's a beautiful example of somebody who had 2 surgeries, but they didn't address the right area. So we know that treating the internal nasal valve is of utmost importance in relieving nasal airway obstruction. And when we look at the general concepts of nasal airway and sleep disordered breathing, we have to understand it's a complex relationship. It's not completely understood in every detail, but we know that nasal obstruction may have a negative impact on sleep quality. And it's really considered a cofactor, excuse me, in the pathophysiology of sleep disordered breathing. So now what I'm going to do is I'm going to kind of turn towards nasal airway obstruction and precision oral appliance therapy. And really, what are the implications for sleep in dental patients? When I have had a few discussions with David in the past, preparing for this talk and this meeting, we happen to talk about the relationship between temporomandibular joint problems and obstructive sleep apnea. And I've been in practice for a long time, for 41 years. And at the beginning, when a patient came to me for a problem with facial pain, oral facial pain, they were a facial pain patient. I never really thought about airway obstruction. And now I look at every patient who has facial pain and say, particularly before I do any kind of oral appliance for temporomandibular joint problems, could they have sleep-related breathing disorder? And this is analogy as well. As an otolaryngologist, looking in people's nose and evaluating their nasal cavity, I think earlier in my career, a patient would come to me for an oral appliance, and I said, okay, they were sent to me by the sleep physician. They failed CPAP or they wanted an oral appliance, and I didn't really critically evaluate their nasal cavity. Now I do it on everybody. And I think it's just part of the learning curve in your career on what things are important to assess. We know in obstructive sleep apnea, we all know this, it's recurrent narrowing and occlusion of the upper airway during sleep. And there's fragmentation, intermittent hypoxia. The Lancet had an article about 3-4 years ago where they looked at the world prevalence of 1 billion people. And US prevalence is 24% male, 7% female. I'm not certain about the numbers in Canada. I suspect they would be somewhat similar. And we can characterize it as mild, moderate, severe, as we know, depending on the number of episodes of apnea per hour. So now, how do we tie these things together? One of the most important things that I've learned in my career is it really doesn't matter what you want, it matters what the patient wants. And, the thing that's so common in the literature now is patient-centric therapy, or, precision therapy, and, or really what we're trying to do is, what is the best form of treatment for that patient? What does the patient want? And, CPAP been around since 1981. We know what the major problem with is that support adherence. And the interesting thing, if you refer to the article on Rottenberg that looked at 20 years of looking back at CPAP compliance, it really hasn't changed. And why don't people tolerate CPAP? There's many reasons why they don't tolerate CPAP, but one of them clearly is nasal obstructive reasons. And a lot of people get very obstructed in their nose. They get nasal congestion, they get sinusitis, and then they are not going to be compliant with their CPAP. And we've seen there's many articles in the literature looking at oral appliance therapy, and it may be equally effective as CPAP when compliance is accounted for. And so nasal airway obstruction is an important thing to understand and to address, because it can compromise both the compliance and effectiveness of both CPAP and oral airway OAT. We know that nasal airway obstruction is associated with snoring and mild sleep-related breathing disorder. There's no linear correlation, and it's not really the main contributing factor to the majority of patients with moderate to severe OSA. But nasal surgery may improve the quality of life, and snoring is a subgroup of patients with mild OSA. It's really not an effective treatment for OSA as such. And I'm sure you've all experienced in your practices patients who you did an oral appliance for, you've reduced, they're sleeping better, they feel better. The sleep study shows good improvement in the parameters or the metrics that we use to evaluate success, and yet they're still snoring and they're unhappy. And part of it could be the nasal contribution in that. So we know that nasal airway resistance is elevated in patients with obstructive sleep apnea. Very little is known about the influence of nasal resistance on mandibular advancement, splint treatment outcomes in patients with obstructive sleep apnea. And, again, the CPAP compliance is that 50% of CPAP users complain of significant nasal symptoms, including nasal congestion, rhinorrhea, nasal dryness, and sneezing. And I think with patients with poor compliance, we really need to do a detailed evaluation of the upper airway to identify obstructive pathology that may be surgically correctable. Powell, who he in 2001 showed that improved CPAP compliance with radio frequency ablation of the inferior turbinate was found, and subjective improvement in nasal obstruction was linked to increased CPAP use. And Friedman showed a mean reduction of CPAP titration levels after nasal surgery, and reduction in pressure requirements were noted in all levels of severity. I'm just going to go through a few studies. This is not about the Vibear. This is about traditional nasal surgery. And this is a study where 50 patients underwent septoplasty conchal surgery. 58% had snoring preoperatively. 42% complained of snoring 5 years postoperatively. The conclusion was virtually impossible to estimate the success rate with nasal surgery for simple snoring. And looking at the relationship, it's very difficult to look through this data and make concrete statements on the relationship, although we know the relationship is there. And here's another study that looked at 14, it was a study of multiple studies, 14 studies on nasal surgery for obstructive sleep apnea, and data on pre and post apnea-hypopnea index. There was little improvement in apnea-hypopnea index, and this is with traditional nasal surgery. Problem with a lot of these studies is different things are done by different surgeons with respect to the actual anatomical surgery that they did, which makes it really hard to analyze the data. And Here's a study in 2002, which showed no significant change in AHI. In 26 patients, nasal resistance was significantly reduced after surgery. Daytime sleepiness was decreased as well. And I think everybody here hopefully is familiar with the Scher's criteria, and this is what's used for surgical success. And there's a reduction of apnea-hypopnea index by 50%, and AHI less than 20. I want you to really code this in your brain, because when you listen to some of the studies by Inspire, and you look at the results about Inspire, and they're happy with a result like this often where it meets Scher's criteria. Yet a lot of you who practice oral appliance therapy, you send the patient back to your sleep physician. They do a PSG or HST, whatever they choose to do, and their apnea-hypopnea index may go from 28 to 9, and then they tell you, geez, this is not successful. And I have to laugh at that, because the reality is for surgical results, if you meet the Scher's criteria, it's considered success. Yet we have pulmonologists every day who will tell you, well, the apnea-hypopnea index isn't under 5, and therefore it was the oral appliance is not effective, and it's simply not true. We all know that. Here's a beautiful example of a patient that came into my office, and I love showing this. This is just one case, but it really illustrates the correlation between these two things. This was a 62-year-old male, 15-inch neck, BMI of 24, Epworth Sleepiness Scale of 9. He had initial HST, and this was 11/6/18. He had an apnea-hypopnea index of 73, RDI of 92, O2 saturation nadir of 82.7%. Now, I think most people who looked at this, well, most pulmonologists would say, this guy cannot have an oral appliance. It will never work. He has severe sleep apnea. He must be treated with CPAP. Well, this gentleman did not want CPAP. It turned out he had polyps in his nose. So I did a endoscopic sinus surgery with polypectomy. We repeated his sleep study. And I just want to point out this is an error, because this should be 2019, not 2009. So please excuse that. The test was done after his surgery. And this is his apnea-hypopnea index, 25, his RDI, 55, and the O2 saturation nadir, 88.3%. So here's his improvement just with nasal surgery. Now we add to this, he was treated with a Prosomnus IA appliance. It was titrated to what's called U2L0, and look at the results. You know, and this is a beautiful example of somebody who had a nasal component to his upper airway obstruction, and neither procedure by itself would have solved this problem. Now, I didn't treat him with the appliance first and then get a sleep study and then do the sinus surgery, because he couldn't breathe through his nose and he needed sinus surgery. So that's the order it was done. But I think it shows the correlation between the two very nicely. So summarizing this, normalization of nasal resistance has a positive impact on well-being and sleep quality, not necessarily on the severity of OSA. And we don't have reliable criteria to identify responders. And so any of these nasal procedures that we do in the, in the hospital, in the operating room, have limited success. Now, I want to show this because this is going to be presented in the World Sleep Congress in Rome. I'm going to be going to Rome in March 10th, I think it is. And this was just a retrospective study done in my office on 115 consecutive patients. And all these patients came in and they had oral appliance therapy. And what it shows is that the results of the patients and what their AHI, even patients in the severe category of an AHI of 51.5 were titrated to a level of 9.9. And I think what's interesting about this is I look at this data from my office. These were just consecutive patients. Nothing was categorized. I had mild, moderate, and severe. You can look at the slide. I assume you'll all get copies of these slides and see how good the data is. And this was before I was really critically looking at nasal airway obstruction when I did this study. And, part of me wonders now, how would it be different if they were critically evaluated for nasal airway obstruction? And I won't know the answer to that right now until we go forward, because now I do it on everybody. So let's now go to the last 15 minutes of this, and we're going to talk about a relatively new procedure that's done in the office for the nasal valve. Okay, and we go back to what is nasal airway obstruction. Well, nasal airway obstruction is trouble breathing through the nose, difficulty breathing during physical exertion, nasal congestion, and difficulty sleeping. Okay, and what I've tried to illustrate in the beginning of this talk is how important the nasal valve is. And if you look at this right here, here's a normal airway on the right nasal cavity, and here's an obstructed nasal airway. And you can see less air is going to get through this space, of course. And what's the impact of nasal airway obstruction? We estimate in the US, there's 20 million people in the US with nasal airway obstruction, and there are 300 million nasal strips sold annually in the US. It's a significant disease burden. It has direct healthcare and indirect socioeconomic costs associated with it. And what happens, it affects the quality of life, sleep, mood, social functioning, difficulty breathing during physical exertion or exercise, lack of productivity, and frequent visits to a primary care office. We all know when you have a cold, you feel terrible. You feel like you haven't slept well. Now, part of it is the viremia, of course, and part of it is you now can't breathe through your nose, so you open your mouth, so you have unstable oral breathing, and you feel miserable. And what about oral appliance therapy candidates with nasal airway obstruction? We know that there's a positive association between sleep apnea and nasal airway obstruction, and medical management of nasal airway obstruction is very limited. We're limited to vasoconstrictors, nasal steroids, saline spray, and it's been determined that non-responders to oral appliance therapy have a higher nasal resistance compared with responders. And that's in Zeng's article that's listed reference 5. And nasal airway and BMI predictors of oral appliance are predictors of treatment success. And we talked about a little bit about the traditional nasal surgery, how it can improve quality of life, but a lot of patients are looking for a less invasive option. So this is what I would like everyone here to do in their office, is when a patient comes in, is to do this evaluation. You can do what's called a nose score, and you take the questions: nasal congestion or stuffiness, nasal blockage or obstruction, trouble breathing through your nose, difficulty sleeping, and struggle to breathe through your nose during exercise. And you have the patient put down 0, 1, 2, 3, or 4. In other words, how significant of a problem is it? And then when you multiply that times 5, that gives you a score, which will put you in either the mild, moderate, severe, or extreme range. Now, what is this? It's just like the Epworth. The Epworth is a subjective test. This is a subjective test, but really what it's telling you is how much of a problem is this for the patient, okay? And this demonstrates here doing the Cottle maneuver. And I think I'll just show this slide. Hopefully this will play on the Zoom presentation.
I'm Dr. Jordan Pritikin. Today we're going to demonstrate the modified Cottle maneuver to assess the patency of the nasal valve. All right, John, do me a favor and take a deep breath in through your nose. Now I'm just going to exert a little pressure here. I'm just going to lift up inside of the nose and just elevate and support that. And now take a deep breath in. And do you notice a difference in your breathing? Yeah. So the key is not to distort the nose, but just to support the nasal sidewall and prevent it from collapsing down. This approximates what we want to accomplish through any type of procedure.
And here's an example of what we call dynamic nasal valve collapse. And watch this here. You can see how the nasal valve is collapsing right here during his inspiration. You can imagine how it interferes with airflow. So let's talk about the Vivere procedure. Very interesting how this was developed. Dr. Scott Wolf is the person that developed this. He's one of these bright guys who's a serial entrepreneur and inventor, and he was instrumental in inventing cool sculpting, which is radio frequency ablation of fat. And once he was no longer involved in the company, he was living in San Francisco, and his son was a lacrosse player, and his son was having trouble breathing through his nose. So he took him to 3 ENT doctors in the Bay Area, and everyone said, you have a problem with the nasal valve. And so he said, well, what would you recommend? And he was told by all 3 ENT doctors, well, you know, the nasal valve is really hard to treat, and we don't really have a procedure for it. One of the things that was done in the past is if the nasal valve collapsed, we would take a piece of septal cartilage, put it in a little pocket here, try and increase the size of this area, put stitches to bring the nasal valve out. And a lot of these procedures that were done were just not effective. So being a smart guy, he decided that he'd go into his garage like they do in California, and he developed the Vivere procedure. He and another inventor, they developed this procedure, and what it is, it's a temperature controlled radio frequency ablation of the nasal valve. They got FDA clearance, and it was marketed in the US about 3 years ago. And then we had something called COVID come our way. And certainly nobody was doing in nasal procedures, in office procedures for a while. But there have been 40,000 done in the United States. And there's data on 6 months, 1 year, 18 months, and 2 years. And the results seem to be extremely well sustained over that 2-year period. Patients often ask, well, how long does it last? Well, with any new procedure, the only way you know how long it lasts is to have the test of time. So we only have data for 2 to 3 years. I don't know if this video is going to play. I'll see if it does. Here's a picture of the procedure being done right now. And what we're doing is looking in the nasal cavity. This is the probe right here, and it's put on the inferior turbinate. And what it does is it's treating it on the left side. The radio frequency is going to penetrate submucosally, and it's going to cause disruption of collagen proteins. And then new collagen proteins form, and it tightens or stiffens the valve. And hopefully you can see this on the left. You can see how it the tissue is well, kind of ablated, so to speak, with the radio frequency. This is called the septal swell body, and so this is being treated as well. This is all done in the office. Here's the same procedure being done on the right side, and here's your probe. Patient first has local anesthesia, topical, and then we inject in the area. And this is treating the inferior turbinate right here on the right side. And he's going to eventually treat the septum here. The whole idea is to open up the components of the nasal valve. I think we'll skip over the rest of that. And you know, what is the mechanism of action? It causes 2 major tissue effects on the nasal airway. It contracts and tightens through the immediate effect on existing collagen proteins, introduction of new ones. And it was designed to cause these tissue tightening effects within the submucosal layer of the nasal valve. And this is the principle of it. And this is such a really important thing to understand. This Sall's law is that you get greater airflow due to tissue stiffening, and you know, airflow is proportional to the force power in the radius. And so a small change in the radius of the nasal valve increases significantly the flow of air. It's really the same principle in essence when you have somebody who's in shock, and you put the principle of shock is to put the largest bore IV in them, so you can push fluids in much faster to hydrate them. And so if you have a 16 gauge or an 18 gauge IV, 16 gauge is bigger than the 18 gauge IV, and the 16 gauge, you look at the size of it compared to the 18, it doesn't seem that much bigger, but the ability to push fluid is dramatically improved because of this physiologic law. And let's show here how the effects are maintained long term. And here's the reduction in the nasal scores. Here's the reduction in the scores of the nose right here, and it's maintained at 4 weeks, 12 weeks, a year, and 2 years, stays pretty stable throughout there. Here's, you'll just see an example of this patient who had the dynamic nasal collapse. Here's breathing after the Vivera procedure is done. You notice in the past that this was collapsing here. And so, how do we process all this stuff? I've given you a lot to think about. Hopefully I haven't confused you, but maybe I have. And there's different nasal procedures that can be done. If it's a primary septal deviation and no improvement with that modified Cottle maneuver, then that would be an OR procedure where we would either reduce the inferior turbinates, maybe do a septoplasty. If it's a primary problem within the inferior turbinate, then it's a clinic procedure where we can do an inferior turbinate reduction. And if it's a primary nasal valve problem, and we feel that at least 50% of the people who have nasal airway obstruction, the problem is in the valve itself, and they would benefit from the Vivera. And how do we put all this together? And I must apologize, the referral from physicians to dentists in Canada is probably different than in the US, and I can't comment on the different silos of care. I know it's been frustrating for all of us in this field, but as sleep dentists or dentists who specialize in oral appliance therapy, what you really want to do is evaluate the patients, have success, and you want to generate referrals from your physician colleagues. So I think what's really beautiful here is that if you start looking for nasal airway obstruction, you will absolutely find it. And it's funny because since this procedure came out, I evaluate every single person for this, and I find that I've found this so many times. And I have my colleagues, they say, well, geez, I don't see nasal airway obstruction that often. Well, you know what? You're not looking for it properly, and you only see what you're looking for. And if you really evaluate people, do the nose score, do the Cottle maneuver, then, and you see improvement when you do that, then more than likely you have a nasal valve problem. You send it to your otolaryngologist, who should have some expertise in dealing with this issue. Again, the Vivera is not yet marketed in Canada. But I'm told it will be. And but the point is if you recognize nasal airway obstruction and you send them to your ENT colleagues, pretty soon they're going to start sending you patients who need oral appliance therapy. And I think it's really a beautiful way to bridge a relationship between two specialties that should be working hand in hand. And just an example here of a patient who had this, the difficulty to breathe is always a problem when sleeping. I would wake up many times, so it was difficult for me to feel rested. Tried over-the-counter sprays. The results were almost immediate. I'm 100%. The sleep is the biggest thing for me, much better than I ever expected. Right now, it's fantastic. And just looking, I think we can go to any of the questions you might have. And certainly, I think that I hope I've kind of taken you through a journey of evaluating the nasal cavity and its importance in its role in nasal airway obstruction.